Hello everyone, welcome back to our new video, and today we are going to discuss the very other important topic, that is the acute rheumatic fever. So when we talk about the acute rheumatic fever, so this is the hypersensitivity reactions. So it is the hypersensitivity reactions to which bacteria? To group A beta hemolytic streptococcus. To group A beta hemolytic streptococcus bacteria. Now, in the patient with the acute rheumatic fevers, the patient will come with the history of the sore throat. The patient will come with the history of the sore throat and pharyngitis. The patient will come with the history of the sore throat and the pharyngitis. Then this patient will having the complicated to cause the acute rheumatic fever. Now, the important question about the acute rheumatic fever, that how we will diagnose this and what criteria we will use for the ARF, acute rheumatic fever. So that is the Jones criteria. That is the Jones criteria. So remember that in the Jones criteria we have the two type of the criteria, like we have the major criteria and we having the minor criteria. So Jones criteria, the one we having that is the major criteria, and another one we will be having that is the minor criteria. Okay, that we will discuss. So major criteria, remember in major criteria also there would be the high prevalence area or there is a low prevalence area. Usually we will consider at everything as the high prevalence area, but there is some area that is having the low prevalence, and there is some area we call that is the high prevalence area. So high prevalence area are those areas like, for example, India. In India, where the rheumatic fever is the highly prevalent. So major criteria we having the mnemonic here, that is the Jones. So Jones. So what is the J for? J for joint. J for joint. So in case of the rheumatic heart fever, you will see the migratory arthritis. You will see the migratory arthritis. Means that if the patient having the pain in the shoulder joint, so after that sometime the pain will be migrate to the knee, and after that the pain will be migrate to the wrist joint. So these are the migratory arthritis. So in the if the low prevalence area, you will see there will be the polyarthritis. There will be the polyarthritis, means joint pain will be there. Joint pain will be there where? At the different regions or the many regions, that is the polyarthritis. In high prevalence regions there can be the polyarthritis, or if there is a monoarthritis also, like if there is a single joint is involved, then also we can consider it as the joint criteria or as a major criteria, or it can be the polyarthralgia. There can be the polyarthralgia, so it can also be considered as the high prevalence area, major criteria for the rheumatic heart fever. What is the difference between the arthritis and the arthralgia? So remember that if the arthritis means that the patient would be having the only pain and the inflammation. So arthritis means the patient would be having the pain, and along with the pain there would be the inflammation would also be present. But if we talk about only the arthralgia, so remember in arthralgia there would be only the pain would be there, only pain only. So if the pain only are there, we call this as arthralgia. If the pain or inflammation both are present, we call that is the arthritis. We call this as the arthritis. So what is the O? The next one is the O. So O is what? Our heart. So your O, it looks like the heart. So what we having, that is the carditis, and is the very complications also, you can say the very important complications, and most probably you will see the pancarditis. You will see the pancarditis. Now, in whether it's a low prevalence area or the high prevalence area, we will consider it as the major criteria, and the most common valvular lesions you will see here. The most common valvular lesions, that is the mitral regurgitation. The most common valvular lesions you see, that is the mitral regurgitation. Okay. After that we will be having the N. And what do you have to remember about the N? So the N means nodules. So N means the nodules. So remember in major criteria we having the subcutaneous nodules. We would be having the subcutaneous nodules. And these subcutaneous nodules, where it will present? It will be present at the extensor surface. So it will be present in extensor surface. It will present on the extensor surface. Then we are having the E. What is the E? That is the erythema marginatum. The erythema marginatum. This is again very important point. This image that is shown in the screen, that is the erythema marginatum. So what you will see in the erythema marginatum, like this is the type of the erythema marginatum, there will be the red margin would be there. So the red margin you will see, and the site where you will see the, most probably it will be on the trunk and extremities. It will be on the trunk and it can be seen on the extremities, and there would be the red color margin. There would be the red color margin of the rashes would be there in erythema marginatum. So red color margin, and where it will present, most probably it will present on the trunk and the extremities. Okay, after that we will be having the another S, and another S is what, that is the syndamchoria. The another S is what, that is the syndamchoria. And the syndamchoria, remember what you will see, there is a IgG against the basal ganglia. IgG against basal ganglia. Which antibody will be seen in the syndamchoria, that you have to remember. Which antibody? S को अगर हमने G बना दे तो कुछ फर्क पड़ेगा. Like this is the S, so in S we can make the G. So S it looks like the G. You can say make the G. So that is the IgG against the which ganglia? Basal ganglia. Or you can remember the S for Suno G. Suno G. S for syndamchoria and Suno G. ठीक है, Suno G. So that is the G means IgG antibody. Okay. What you will see in case of the syndamchoria? What you will see in the syndamchoria? In the syndamchoria, remember, there would be the external hand rotation. There would be the external hand rotation will be there. The external hand rotation will be there. And typically we call this condition as the scooping. We call this condition as the scooping. And in syndamchoria, the patient will be having like the milky action. The patient will be having the milky action would be there. And both these are the late manifestations. The important things you have to remember, that the patient with this, if the patient has got the syndamchoria, remember this is the late manifestation. This is the late manifestation. You have to remember this is the late manifestation, and this is the common in females. This is the common in females, more common in the females. These milky actions, like when the patient is trying to alternately squeeze and release, the patient will trying to alternately squeeze and the release, squeeze and the release. This milky action will be decrease in the sleep, or the scooping will also decrease in the sleep. So these syndamchoria features the external hand rotation that we call the scooping, and the milky action would be there, the decrease in the sleep, and the late manifestation can also be there, that is the common in the females. That is the common, the syndamchoria, this is the common in the females. So they will see that there is this is the decrease in the, so we have seen that this is the decrease in the sleep. So what we have, we can give the treatment that if the syndamchoria, we can give the sedative drugs. So the patient will go into the sedation. So these features, or the clinical features will be decreased. After that we will be having the minor criteria. After that we would be having the minor criteria. When we talk about the minor criteria, so remember again we will be having the low prevalence area and high prevalence area. The criteria is different for the both prevalence area, whether it is the high prevalent area and different, and for the low prevalence it is different. So who is making the FIR? That is the ACP. तो इसको मैं ऐसे याद रखता हूँ, that is arthralgia. So what is the arthralgia? In low prevalence area we consider that the polyarthralgia is the minor feature, and here we consider as the monoarthralgia, it is the minor feature, because in high prevalence area the polyarthralgia is the major criteria. Then we will be having the fever. The fever again, if more than 38.5 degrees Celsius, we consider it as the low prevalence area, and if it is a more than 38 degrees Celsius, we consider it in the high prevalence area. The ESR more than 60 here, and it with the more than 30, we can consider it as the minor criteria for the rheumatic heart disease. If the CRP, the C reactive protein, if it is increased that in both conditions, then it is the undergoing under the minor criteria. Then there is a PR interval. There is the PR interval, and the PR interval, like when we are doing the on the ECG, so what you will see, there is increase, yani ki prolonged. That will be the prolonged, or also here it is also prolonged here. Okay, so what you have to remember, the first things you can remember, the arthralgia. Okay, you can write it like that: ACP, ACP, ACP. What is ACP? FER. Okay, ACP, FER. So this is the four. So what is the ACP? ACP is right. What is the ACP written? FER, FIR. Okay, so this is the FER. So A, CRP, PR interval. So arthralgia, CRP, and the PR intervals, or we would be having the fever and the ESR. They all are the minor criteria, and the difference in the low prevalence area and the high prevalence area. The low difference in the high prevalence and the low prevalence area. If it is not mentioned which is the low prevalence or the high prevalence, then assume that they are talking about the high prevalence area. Okay. How you will make the diagnosis? How you will make the diagnosis? So remember that definitive diagnosis would be made. The definitive diagnosis would be made with the help of criteria, with the Jones criteria. And in the Jones criteria for the diagnosis, remember, we take the two major or one major plus two minor. So you can remember do bara. So 2, 1, 2. Remember the do bara, either two major criteria or one major plus two minor. So you have to remember do bara. तो acute rheumatic fever में हम क्या कर रहे हैं? दो बारह कर रहे हैं. क्या कर रहे हैं? दो बारह. So you can remember it as the दो बारह. So दो बारह are there. तो दो बारह means two major criteria या फिर or one major plus two minor criteria would be there. Along with that, we would be having one, there is a essential criteria. We would be having the essential criteria. In essential criteria, remember, we would do the evidence of the prior streptococcus bacteria, evidence of the streptococcus infection bacteria evidence. We will take the evidence of the streptococcus infection, and remember that if we have to do the streptococcus infection, what we will do? We will take the throat culture. We will take the throat culture, or we have the ASO, anti-streptococcus O titer will be increased, or what we will see, the strep antigen will be positive. So if this criteria is possible, so we will call this as the essential criteria. If in the major criteria, syndrome chorea, if the syndrome chorea it is present, if the syndrome chorea is present, then the essential criteria is not needed. Then the essential criteria is not needed. Okay, so if the syndrome chorea is present, the essential criteria is not needed. Because it is the, we have discussed that it is a late manifestation. If the late syndrome chorea is present, means that definitely the patient is having the rheumatic heart disease. Now we will be having the another very important thing in the acute rheumatic fever, that is the profile axis of the acute rheumatic fever. See, when we talk about the profile axis of acute rheumatic fever, in the profile axis of acute rheumatic fever, remember, there would be the type of profile axis. There would be the type of profile axis. When we talk about the type of profile axis, so there are two types. One we having the primary, and another we would be having that is the secondary profile axis. We would be having the secondary profile axis. So in the primary profile axis, what you will see, like for example, if there would be the pharyngitis, I told you there is a history of the pharyngitis or the tonsillitis. So if the pharyngitis is present, and if the pharyngitis it is not progressed to the acute rheumatic fever, so in that condition we will give the primary prevention. In the primary prevention, we will give the single dose of benzathine penicillin. What will give? The single dose of benzathine penicillin will be given within 9 days of profile so within the 9 days of pharyngitis, within the 9 days of pharyngitis. So if we will be having the pharyngitis present, so if the pharyngitis is present, so we will we can prevent the acute rheumatic fever by the single dose of the benzathine penicillin within the 9 days of the pharyngitis. And how many unit we will give? That is the 1.2 million unit would be given. Then if the secondary prophylaxis are there, in case of the secondary prophylaxis, so remember that if we will be having the acute rheumatic fever, it is present. If acute rheumatic fever is present, then already if the acute rheumatic fever is present, then we have to prevent the recurrence of the acute rheumatic fever. So in that condition, what we will do? We will do the secondary preventions. Remember that the drug of the choice is also here the same thing. The drug of the choice is the same. And which drugs will be given? That is the benzathine penicillin. The benzathine penicillin 1.2 million unit. Then see, if we have the benzathine penicillin we are giving. So remember that when we are giving the benzathine penicillin, we will check about one major criteria. And which major criteria will be given? That is the carditis. If there is a no carditis, the patient having the acute rheumatic fever and there is a no heart involvement, then what we will do? We will give the benzathine penicillin for how many years? 5 years, or till patient age 21 years, or the patient is 21 year. If there is a no carditis, if the no carditis means the 5 year are there or till the patient is 21 years, then we will give the benzathine penicillin. Then if the patient were having the carditis, if the patient having the carditis, so what we will do? The 10 year, what will the 10 year or till patient is 21 years. Okay, so if no carditis means the 5 year or till the patient age is 21 year. Whichever will be the last, whichever will be the longer durations, we will give then accordingly. So we can write here whichever will be of longer durations, whichever will be of longer duration. For example, if 17-year-old, if the 17-year-old girl with coming with the acute rheumatic fever with the no carditis, so in that girl, what we will do? We will continue the treatment for 17 plus 5, so it will be the how many? 22. So we will continue with the 22 years. We will continue till 22 years. Okay, the same thing, like for example, if we will be having the patients coming at like 13 year, with the 13-year-old with the no carditis, then we will continue till 21 years. Whichever of the longer duration, we will continue that one. Okay, then the next one, if patient having the rheumatic heart disease. So if the rheumatic heart fever, they complicated to form the rheumatic heart disease, and this is what? That the chronic complication. So in that condition, we will give the lifelong treatment. We will continue with the lifelong treatment. The benzathine penicillin will be given lifelong. Okay, so that you have to remember, and this is, remember, very important point. If you having the single dose of the benzathine penicillin, the primary prevention or the secondary prevention, both the prevention are really very important. And remember that the benzathine penicillin, it is given every 3 weeks. It is given every 3 weeks. Every 3 weeks. Okay. And remember that if you are having the acute rheumatic fever, so this is the cause of what? The most common cause of the valvular heart disease. So this is what that about the acute rheumatic heart fever and the prevention of the acute rheumatic fever, the Jones criteria, the major and the minor criteria. In major criteria, remember, we will be having the Jones, that is the joint carditis, nodules, erythema marginatum, and the symptom chorea, and the minor criteria are ACP, FER, that is the arthralgia, CRP, PR interval, any case that will be the prolonged, and we will be having the fever and the ESR, the more than 60 in the low prevalence area and more than 30 in the high prevalence area. Okay, so this is what that is about the acute rheumatic fever. I hope this video is helpful for you. Please do share this video as much as possible to your friends, to your colleagues, to your juniors, to seniors, and subscribe this channel for more videos, and do comment if you like this video.